Good morning, good evening, good afternoon from Australia. I'm Jarad Martin, and many thanks for the kind opportunity to present our randomised trial in Dupuytren's disease, looking at the role of radiotherapy, which I'm presenting on behalf of all my collaborators, and it's a really exciting opportunity to be able to have the opportunity to do so. Just in case you're wondering where Newcastle is, this is exactly where I live, with 3 beaches within a 15-minute walk, and a fantastic couple of radiotherapy centres and climate, and hopefully we'll get a chance to welcome some of you to this part of the world at some point in the future. So without reiterating too much, but one of the things with Dupuytren's disease is obviously there's a prodromal phase where there are inflammatory nodules, which could potentially be a target for radiotherapy to halt the progression into the later phases. And then obviously there's a functional phase with contractures at the end, where it may be that radiotherapy might have a role after definitive procedures have been done to consolidate the gains and potentially prevent contractions from reoccurring. The main target cell we're looking at are the fibroblasts, as we've heard elsewhere in the symposium, and for an oncologist, when you have a proliferating subpopulation of cells, whether they're malignant or not, they can be a great target for an anti-cancer agent, and particularly when they're localized to an anatomical structure such as the fascia of the hand, we have the opportunity to use radiotherapy in a targeted manner to potentially deal with that. So we do have the potential to slow early Dupuytren's disease, but given the uncertain natural history where the disease may have a very long natural history anyway, it may well be that we're intervening for a disease that is going to burn itself out or progress extremely slowly. Similarly, it can be used as an analgesic for discomfort from nodules, but once again, this usually does spontaneously improve after a few months, and hence an intervention may not be in the patient's best interests. We can manage the whole palm at once, the whole fascia, and potentially reduce the risk of other invasive treatments being needed further down the track. Professor Schmidt has performed a randomised trial in this area, really between 2 different dose levels for the prevention of progressive disease for Dupuytren's. However, the observation arm was a patient and clinician decision rather than a randomisation. And partly on the basis of that, a lot of national and international bodies have really decided that radiotherapy needs more evidence. And this is one from the British National Institute for Healthcare and Excellence, really saying this should be done as part of a trial or some other sort of audit process. And just illustrating why randomised trials for radiotherapy in benign disease are important. This is one that came out from the Dutch looking at radiotherapy for osteoarthritis, and without delving too much into the detail, the main finding was that compared to sham radiotherapy, there was no difference as far as their analgesic relief achieved by radiotherapy, and hence justifying why really proper randomised trials are needed in this space. This led to us to develop the DPAR trial, which is looking at Dupuytren's disease, the evaluation, both in the preventative and adjuvant phases with the use of radiation therapy. So in the prevention part of the trial, we're really taking people with less than 10-degree contracture, no previous management of the affected hand, and have had some evidence of progression over the last year, either with new nodules or some loss of extension, hyperextension. And we've limited the age to greater than 30 as well to reduce second malignancy risk. It's been a significant factor. But patients get randomised to either observation, which is obviously the standard of care at the early phase of the disease, or they get randomised to 10 sessions of low-dose radiotherapy given in a split course. So we'll give 1 week's worth of treatment followed by between a 4 to 12 week break, but usually around 6-week break, and then another 5 sessions. And this was really taken for what we judged to be the best performing arm of the Schmidt trial. In the primary intervention, we've really borrowed from a lot of the collagenase trials and other research in this field about what proportion of patients end up with a greater than 20-degree contracture in that hand, or needing some other definitive intervention such as surgery or a minimally invasive approach. Possibly more excitingly, we're also looking at radiation in the adjuvant setting, because clearly there's a whole bunch of treatments that can be used, although collagenase has limited availability outside of North America now, and needle aponeurotomy. Although they all have significant relapse, somewhere between a quarter and a half over a 5-year period. Radiotherapy has been explored in a number of other indications, and I guess the keloid scarring, following resection of that, the application of radiotherapy has got some merit in reducing the risk of the keloid reoccurring, and that's similarly another hyperproliferative fibroblastic disease. So really just borrowing from that literature, hoping that we can dampen the fibroblastic response and reduce the risk of contracture. So we had another 3 parts of the trial for patients who've really had any definitive local treatment, age over 30, randomizing them to either observation as standard or a similar 10-day course of radiotherapy that's to start within 4 days of the intervention. You can see the numbers there needed based on a hazard ratio of 0.5, looked for the effect of the radiotherapy in the same primary endpoint as in the prevention study. And just a few examples. This is a patient who had a surgery on both hands, the right hand in the past, you can see the scar on the 5th digit, and then the left hand more recently on the 4th digit, and that patient got randomized to the radiotherapy, and even halfway through the second lot of the radiation, the scarring is becoming quite difficult to discern. This is a patient on the percutaneous needle aponeurotomy arm, and once again, a couple of months down the line, it's hard to sort of see either where the scarring is from aponeurotomy or any effects from the radiotherapy. We do have a multidisciplinary clinic, which we run with our hand surgeons and hand therapists, and we try to educate our patients and really offer many of them the trial, which now has many sites open and hoping to go international in the Netherlands soon. And thus far, we've got around 250 patients enrolled across all arms of the trial. So we really want to promote this trial and establish a collaboration. And this is the team involved. Many thanks to them all, and many thanks to you for your attention. Thank you very much.